Good morning. Today we will have a operative surgery discussion, uh, which will be presented by Dr. Sritama Rai, who is a first year DNB student at Ruby General Hospital. And today our moderator will be Dr. Dhritiman Moitro, who is Associate Professor of Surgery at Calcutta Medical College. Dhritiman will start with the hemicolectomy open, and then if the time permits, go to laparoscopy.
Okay.
So we can start.
Okay, sir. So good morning, Dr. Sritama.
Good morning, sir.
So today's discussion will be about left hemicolectomy. So can you tell me some indications of left hemicolectomy?
We have most commonly it's done for left colonic malignancy. That's either from the left part of transverse colon containing the splenic texture, the descending colon, or the sigmoid colon. And other than carcinoma, we also have other indications it's also done for perforations that are by non-antigenic trauma. It's done for sigmoid vulvosis sometimes, obstructive pathology. Um, if there is any polyp with indications of malignancy or ischemic colitis, we also
So for polyps, we should be a little more specific. Polyps, sessile polyps, which cannot be removed by endoscopy, or even pedunculated polyps with a Haggett-4 type of carcinoma involving the base of the polyp, with indications that it could be a high-risk polyp for lymph nodal metastasis. So what are the features of a polyp which indicates that there is high possibility of lymph node metastasis? If the cancer is poorly differentiated, if there is lymphovascular invasion, etc. And the base of the polyp is involved. Okay. So, with these indications in mind, you have a patient. How will you prepare the patient for surgery?
We have to do general preparations, like general condition of the patient, like nutrition, hydration status, and after that you also have to do the routine blood investigations that like have the serum potassium, sodium, urea, LFTs.
Routine investigation. That is fine. That is fine. Next, you tell me about the salient points of patient preparation with respect to mechanical bowel preparation, antibiotic prophylaxis, and ERAS protocols.
Okay, so mechanical bowel preparation consists of we can do it by a lot of ways. First is bowel wash by polyethylene glycol a day before surgery. If you like mix one pack of peglet powder in 1 liter of water, and other than that, there is also saline lavage by if we put normal saline through the rice tube at the rate of 2 to 3 liters per hour, and until clear liquid passes through the clear liquid passes out, and when that happens, you have to continue. Yes, sir.
Okay, what is the alternative for peglet? In peglet, you have to give a lot of volume of water, about 2 liters. Now, what is the alternative where you can give less amount of fluids? Sodium phosphate fleet solution you can use, but you cannot use that in patients with renal failure, AKI, or congestive cardiac failure. But what does the literature suggest? Is there any advantage of using mechanical prophylaxis? What is the evidence? Mechanical bowel preparation, is there any advantage?
Sir, according to ERAS protocol, they say that there is probably more, there can be more harm than good by mechanical bowel preparation, because the substances used might cause edema of the bowel, and that may be a precursor for anastomotic leak earlier after surgery.
And also there will be loss of
electrolytes.
short chain fatty acids also, because bacteria will be washed out and the enterocytes will not get the nutrition. It is not only the EDAS protocols, there have been several RCTs which have proved that mechanical bowel preparation may not be helpful in preventing anastomotic leaks, etc. But what is the obvious advantage of doing mechanical prophylaxis? If the gut is cleansed of all the stool, etc., then there will be less spillage, and for you, it will be easier to handle the gut. What is the drawback of these RCTs that have been done for mechanical bowel preparation? In these RCTs, mostly the patients have received only mechanical bowel preparation, and they haven't taken into consideration what will be the effect if mechanical bowel preparation is combined with antibiotic preparation, like with neomycin and metronidazole. Okay. However, recent studies have shown that when you are using antibiotic prophylaxis along with mechanical bowel preparation, that is marginally better than only mechanical bowel preparation, and hence you may use mechanical bowel preparation along with antibiotic prophylaxis with neomycin and metronidazole. Now you tell me, what are the EDAS protocols?
Ditiman, this is now more people are in favor of doing bowel preparation who is doing left colectomy.
Yes, yes.
Yeah. Right hemicolectomy preparation is not mostly not required, but for doing left hemicolectomy or anti-resection, people do go for bowel resection because in our patient population, the stool load is more.
Yes. Handling becomes much easier, spillage is less, surgical patients may.
In PG level, there is no one line saying that no preparation or preparation in all cases. There should be some discussion. There are some advantages and there are some disadvantages of this bowel preparation. And particularly in left colonic section, bowel preparation is still indicated.
What are the EDAS protocols about keeping the patient NPO, etc. for colonic surgery?
Colonic surgery, we can give chewable food till 6 hours pre-operatively, and we can give clear liquid in form of carbohydrate loading 2 hours before surgery. And
what is the advantage of doing carbohydrate loading?
This prevents post-operative post-operative hypoglycemia and insulin resistance.
Good. And if the patient is taking orally till almost the time of operation, 2 hours prior to operation, they're taking fluids and all, the patient has less anxiety and the patient is in a metabolically fed state. That is what they say. Okay. So using EDAS protocols may be a bit controversial in what conditions? Diabetes, because diabetic patients may have delayed emptying and delayed colonic movements. So in such patients, it may be controversial to use EDAS protocols or to feed the patient till 2 hours before operation. Okay. So with this in mind, now the patient is on the operating table. What will be the position of the patient?
Here for left colonic surgery, like left hemicolectomy, we put the patient in Lloyd Davis position, which is head down position. And
we are discussing Sritama, we are discussing right hemicolectomy actually.
Left.
Sorry, I was said left.
Oh, left. Okay.
So we are putting the patient in Lloyd Davis position, that is head down position, and the legs are spread out. It's basically used for any urogenital or colonic surgeries.
See, basically supine position is sufficient for left hemicolectomy as such. But you may keep the patient in Lloyd Davis position so that you have an access to the anal opening and you can do intraoperative colonoscopy if you want. If you are supposedly you are removing the sigmoid also because of a low left colonic mass, and you want to do a staple closure using a circular stapler, then also it will be easier to access the anal canal if you have kept the patient in a Lloyd Davis position. Now, keeping the patient in a mild Trendelenburg obviously helps by a bit turned to the right helps by exposing the field of operation. Okay. What incision do you prefer?
So midline incision is preferred
What is the
more
alternative?
to the alternative that we can have a
Paramedian.
left-sided oblique incision, but
Any
yes, left
oblique
paramedian. Sorry, not oblique, paramedian.
incision is not preferred.
Yeah.
You may give a make a paramedian incision if you want. Okay. Now you have got inside the abdomen. How will you? What will be your steps of operation?
So first, we have to do an exploration by laparotomy. So first we have to check whether the tumor, the general condition of the abdomen, whether there is ascites, whether there is any distant metastasis that can be observed on the liver or in the peritoneum. If the part of the colon that we are planning to remove is attached to the surrounding structures, like if it is attached to the ureter or the retroperitoneal organs, or you
If
could
there
see.
is a preoperative suspicion of ureteric involvement, abutment, etc.,
We have to
what
do a
should you do?
stenting. So we have to do a
You do
stenting.
preoperative ureteric stenting. Okay. Now you have assessed for operability. You see that the mass is resectable and there are no there is no
Distant metastasis.
there is no tumor met or peritoneal met. So you will proceed with operation. So how will you
Yes.
proceed? This is
So
open
the
operation. So approach is
open operation.
lateral
So
to
open
medial.
operation, yes, lateral to medial. So first we mobilize the small intestines to the other side so that we can get a proper visualization of the splenic
Mobilizing.
section.
Small bowel is
Pack.
mobilize. You pack it off.
Yeah,
Pack it off.
move it up, yes. And then we start we have to start peritoneal dissection from then first we have to check the sigmoid colon area if there is any adhesions to adhesions below and to the
If you have
pelvic organs.
planned,
So
if you
that
have
the
no,
adhesions.
see, if there's a very distal left colonic mass and you have planned that you will take the sigmoid colon, then you start by mobilizing the sigmoid colon. It is because it is relatively mobile. You cut at the line of told and you start mobilizing the sigmoid and go up gradually. What is go up gradually? So what are the structures as you mobilize the colon from lateral to medial? What are the structures that you should be careful about?
So we have to be careful of lateral to medial. We have to be careful about the ureter and gonadal vessels.
Left ureter. Be
The
specific
kidney,
because this is left
left ureter,
hemicolectomy. You say left ureter. Okay.
left
Then
ureter, left gonadal vessels, left kidney,
what do you
and
do
as
to
we
the
go
gonadal
upwards,
vessels?
also that
What do you do to the gonadal vessels?
we have to the ureter and the gonadal vessels. We have to push them down so that we do not injure the structures while dissecting.
You may
So when we start dissecting from
ligate the gonadal vessels also to prevent a situation where there may be, the vessels are not ligated and in course of dissection, if they are traumatized, if they're injured, then there will be severe bleeding. So it is better to electively tie them. Okay. Then you try to protect the ureter. You loop it out of the field of operation. Next, you go up. Now you
so
reach
we
what?
start yes. So we reach till the sigmoid, the splenic flexure upward, and then from splenic flexure.
Now here, from here, like after you have identified the ureter and you have tied the gonadal vessels, you can either continue with mobilization or you may apply the principles of no touch technique of Turnbull and try to secure the vessels first instead of doing further lateral mobilization. So either way you can do. Now suppose you are doing by no touch technique or early vascular ligation. So what are the vessels that you will ligate for left hemicolectomy? After you have identified the ureter and the gonadal vessels, you will try to look for the
Yes, I have to look for the pedicle of like the IMA. I have to look for the the vascular pedicle of IMA. So while doing that, we also have to be careful of sympathetic nerves and the hypogastric nerves behind, because injuring them will cause the post-operative complications electrolyte ejaculation in males and vaginal dryness in females, and also
If see, if you are doing only left hemicolectomy,
Yeah.
you may tie up to the origin of left colic only. You do not need to tie the inferior mesenteric artery up to its origin. If you are doing anterior resection or you are removing the sigmoid, then you may do. But again, there is controversy whether you should tie the inferior mesenteric at its origin, or you can tie the inferior mesenteric below the origin of the left colic if you are doing only anterior resection. So
First,
in this,
Sriman, she can answer that before she decide about the vascular ligation. How far you are going to resect in a standard left hemicolectomy? Suppose it's a
yes.
descending colon mass. You are doing a standard left hemicolectomy. What should be your line of resection?
Okay.
Then you decide about the vessel.
Yeah. So we mobilize the descending colon, and we move upwards. We mobilize the splenic
How far you
flexure,
resect?
and then
How far you
How
resect? Just a line of resection, and then discuss
So
how do you do that.
the transverse colon, the right, we basically resect till the left side of the transverse colon in left hemicolectomy. So we have to make the dissection till divide the peritoneum, we divide between the greater omentum and the plane between the transverse colon and greater omentum. And after that, we identify
the
the
territory supplied by the left branch of the middle colic.
Middle colic. Yes.
Okay.
left cord vessels of hemicolectomy.
And
And then
downwards,
distal
you may
dissection from the tumor margin.
From the tumor
For
margin,
instance.
sir, 5 centimeters.
Yes.
5 centimeters.
5
standard
centimeters.
in
Yes.
standard hemicolectomy 5 centimeter. Now we will come to some other concepts later on. You will see. So left colic you will tie, and if you are doing by no touch technique of Turnbull, left colic and inferior mesenteric vein you have to identify, and you have to tie the inferior mesenteric vein as high up as possible below the pancreas. Now when you have tied these two vessels, you can carry on with the further mobilization. So you said that you will mobilize near the splenic flexure. So what are the problems that you may face during mobilization at the splenic flexure? Huh? You have to be particularly careful to see that there is sometimes what happens, overzealous retraction by the assistant may lead to capsular tear of the spleen, or there may be rupture of vessel. There is a leash of vessel around the splenic flexure. So those vessels are very fragile and they may tear, and there may be severe bleeding from the either those vessels or even from the spleen. Now, if there is splenic bleeding from the spleen, how will you manage? What will you do at that point of time?
Bleeding from spleen.
You will pack off compression and see for some time, because straight away you do not jump for splenectomy. You wait, you see whether the bleeding can be controlled by pressure, packing, etc. If not, you may go for splenography or splenectomy along with colectomy. Okay. Now, what other important structure will you encounter as you go further now towards the right from the splenic flexure?
We have to be careful of the duodenum and the pancreas.
Yes.
Duodenum is further to the right, but pancreas. So you may end up damaging the tail of pancreas while trying to dissect. Now, what do you do to the greater omentum? When you are doing left hemicolectomy, we know for right hemicolectomy, we should take a part of the greater omentum and we should cut the omentum from the margin of the, from the border of the stomach, so that we can take a lot of greater omentum and you can enter the lesser side. What with left hemicolectomy? How much omentum should you take? Is it mandatory to take omentum?
Hemicolectomy, we just make a place between the transverse colon and the greater omentum. We don't have to take.
It is
I
optional.
think we don't have
It
to.
is optional
Yes,
as far as literature is saying that distal greater omentum may not be removed with the specimen in case of left hemicolectomy. Like it is mandatory in right hemicolectomy, it is not, or transverse colectomy, it is not so in case of left hemicolectomy. Okay. Now that you have mobilized, how will you take out the specimen?
Okay. So after mobilization, immediately first
So
we
you
have to
will,
get the artery and the vein first.
it has been done.
Okay. After that, we have to colon can be divided by staplers, or
Okay.
we can also use intestinal clamps for division.
Okay.
And after that,
Sitama,
we have to,
in exam you describe one technique. Sitama, you describe one technique, and then let the question be first. Describe one technique.
okay. So by mechanical stapler, I should mention only also, like just mechanical stapler.
So you have cut with
What
staplers.
stapler?
What stapler?
What stapler?
So linear cutting stapler.
What, 60, 80?
Um,
And what kind of cartridge will you use? Green, blue, or colon? For colon, you can use blue cartridge, and colon, the length is such that you can cut with 60 also, unless it is very dilated. If it is very dilated, you can use 80. Okay, now you have cut. Then how will you restore continuity?
So we have to see if the splenic the remaining the proximal end of the colon near the splenic flexure, whether it is properly adequately mobilized so that we can have a tension-free anastomosis from there to
Tension-free
the.
anastomosis is the key. Okay. Next, how will you restore continuity?
So we can either do hands-free anastomosis can be done.
If you are doing hands-on anastomosis, how many layers will you prefer? What kind of suture will you prefer? Would you prefer continuous or interrupted?
No. Sitama, you have fired a stapler. You have already fired a stapler. Now why do you go for a hands-on? If you have access to the stapler, you stick to that, you will do stapler anastomosis.
Then we will discuss.
You have fired two linear cutter. You have fired two linear cutter. Now you have two closed ends. You have mobilized the proximal colon so that it comes comfortably to the lower resected part. How do you do a stapler anastomosis? How do you do a stapler anastomosis when you have two cut ends? What do you do? What is that anastomosis called as? This will be anatomically side to side, but functionally anatomically side to side, but functionally end to end.
Yes.
Got my point? You have two cut ends, it's stapled. Now we are going to do a stapler anastomosis between the two cut ends of the colon. So what do you do?
What are the steps?
In the stapler anastomosis, we have to use the anvil to the proximal part.
No. You are using side to side stapling by linear cutter. So how will you introduce the two ends?
From the lumen of the stock.
You have applied staples to cut the specimen. Both the ends are now stapled. So what can you do? You can make small enterotomies, enter into the lumen, distal and proximal, and then fire the stapler and then close the enterotomy. This is one way of doing. Then if you hadn't applied staplers and you had applied cut between clamps, then you could have used the triple stapling technique. You could have used the triangulation technique of anastomosis. Now, if you have also taken out sigmoid colon and your distal end is quite low, you can use a circular stapler for closing also. If you are using circular stapler, then how do you introduce the anvil? Into the proximal end, you put the anvil and put a purslin around it, and the distal part of the gun, you enter the anus and open the stapler so that the pointed part comes out through the anterior surface of the distal stump, and then you oppose the two. You put the
You
anvil
burn
on the
and then take out
hook, and then you close it and then fire it. So this is one
and
thing.
then fire.
Okay. Suppose staplers are not available and you have to do sutured anastomosis. So what do you prefer? What kind of sutures do you prefer?
So for colonic anastomosis, we can use PDS sutures, like 30 PDS can be used.
30
What type of
And some,
technique of anastomosis?
sorry, sir?
Technique. Suture is 30 PDS, fine. Technique. How will you do that?
Sir, end-to-end anastomosis can be done hands-on.
How do you take bites?
Interrupted or
Sir,
continuous?
pseudomascular,
Single layer
sir,
or
yeah,
2 layer?
sir, yeah, single layer interrupted.
Yes.
Single layer
Single
interrupted
layer
is best.
interrupted and
By
then
chance-
extramucosal stitches.
By chance, if somebody wants to do continuous also, in some books it is coming, but you have to do, if you are doing continuous, you should do 2 layers. But the preferred is single layered interrupted 30 PDS. Okay. Okay. Now tell me whether you will do a diverting ileostomy or a loop ileostomy to protect the stoma, whether that reduces the leak rate or not.
Uh,
For a standard leg hemicolectomy, is it a routine to do a diversion?
No.
yes, sir, for earlier, I think
No, if you are suspicious that there was very severe stool load, there was edema, and you are not sure whether the anastomosis will heal or not, patient has low albumin, then you may do. But it has been seen that even if you do a diverting stoma, it does not reduce the leak rate. What it does is it makes the leak more manageable, easier to manage. Okay. So it is not mandatory to do. Next, you have dealt with a standard left hemicolectomy. Now, what is the concept of complete mesocolic excision and central vascular ligation? Sitama?
so concept
For malignancy,
so-
now that is the standard of care. For malignant lesion, standard of care is the total mesocolic excision.
extra and the central venous ligation. So in central venous ligation, we have to ligate from the vascular pedicles, and we have to mesocolic excision. We have to remove the entire mesocolon from.
What is the extent of the mesocolon? For rectal excision, we know that we go in the plane in between the fascia propria of the rectum and the presacral fascia. Now, with colon, what is the plane? See, the transverse colon and sigmoid colon, they are less adherent to the retroperitoneum, whereas the left colon is more adherent to the retroperitoneum. So when you try to go between the fascia propria, that is mesocolic fascia, and the retroperitoneal fascia, you may find severe adhesions in the area around the left colon or the descending colon, especially around the splenic flexure, where above, it is invested over the pancreas, etc. So you have to be very careful that you do not breach into the mesocolon while doing this dissection. So this is one part wherein you are removing all the mesocolon anterior to posterior, like there is no breaching into the mesocolon. Now, what will be the extent along the vessels? You tell me the groups of lymph nodes that are present around the colon, how they are named. What do you mean by epicolic node, paracolic node, which both of them together are called pericolic? And then you have intermediate nodes and principal nodes. How do you name them?
So epicolic nodes are located at the walls of the colon.
Yes.
Pericolic.
Pericolic along the marginal artery of Drummond. Paracolic is along the marginal artery of Drummond. Okay. Intermediate is along the named vessels like cleft colic, etc. And principal is along the inferior mesenteric artery, superior mesenteric artery. Yeah. likewise. So when you are doing a complete mesorectal excision, your aim is not only to remove the entire mesocolon of that part of the gut, but also to remove all the lymph nodes that are there in that area. So you must remove the epicolic, paracolic, which together are called pericolic. Then you should go to the intermediate, and if needed, you should also remove the principal nodes. So you have to do ligation of the vessels from their origin. Now, in this, you are removing all the mesocolon as well as the lymph nodes. Now, there is a concept by the Japanese which is called D2 and D3 lymphadenectomy. There, they are not emphasizing on mesocolon, but they are talking about D2 and D3 lymphadenectomy. Do you have any idea about what it is?
Sir, I think in D2 we have to remove some of the lymph nodes around the yes, no, yes.
No. For D, they are saying that for tumors involving up to the submucosa, you do D2, and for tumors involving the muscularis, you do D3. Now in D2, for left hemicolectomy, suppose, for D2, you are supposed to remove all the lymph nodes up to the origin of left colic. That is fine. And for D3, you have to remove the fibrofatty tissue overlying the inferior mesenteric artery also. Here also, they are not emphasizing on taking the inferior mesenteric artery from its origin if you are doing only left hemicolectomy. Okay. So between D2 and D3, the difference is taking the fibrofatty tissue overlying the main principal group of nodes overlying the inferior mesenteric. Now, what is the difference between complete mesocolic excision and D2, D3 dissection? It is about the length of specimen. In D2, D3, you are focusing on the lymph nodes only. You are going from the colon up to along the vessels, along the arteries. There, the emphasis is not there on removing the entire mesocolon. So, length of specimen is a bit smaller in D2, D3 compared to CME with CVL. So these are the basic differences between the two. Now, you tell me, what is the role of neoadjuvant therapy? If you are planning a patient, in what conditions will you plan neoadjuvant therapy and with what?
Neoadjuvant is given in stage 2, sometimes stage 2, not always. Depending on the invasive, the kind of
T3
tumor.
tumors. T3 tumors in the stage 2.
Yes. So
And above, you will give.
So
if there is a T4 tumor, you may also have to give neoadjuvant radiotherapy. Neoadjuvant radiotherapy if there is a T4 tumor. Now, what is the, you tell me, hello, am I audible?
Yes.
What is the evidence? What is the evidence of using targeted therapy in neoadjuvant setting? Like bevacizumab, cetuximab. It has been seen that in neoadjuvant setting, there is no advantage of using these, and hence they are not used. Okay? Hence they are not recommended. Next is, you may be asked, in certain groups of patients, using targeted therapy may be actually detrimental. What are those groups of patients? RAF mutation, KRAS mutation, if these are there, using EGFR inhibitors is detrimental. Now, in what patients will you test for MMR mutations? Tumors which are to the right of the splenic flexure, and these tumors, you remember, have a better prognosis and less chance of recurrence. So chemotherapy is sometimes used a bit conservatively in these cases. So these are the few things. Now coming to laparoscopy, what are the port placements for left hemicolectomy?
So we use a umbilical port, and we have a left right-sided port and the anterior iliac spine level, which can be a 12 port, and we have 2 other 5 ports in the left and right flanks.
You may use a supraumbilical port. It does not need to be umbilical. You may use one in the midline below the umbilicus, midway between the umbilicus and the symphysis pubis. You may use 2 more 5 mm or 110 and 1.5 on the RIF and LIF. Now, how do you proceed?
So laparoscopy, the main thing is that we have to go from medial to lateral. That is supposed to be the approach. And first we have to the same position. The patient position is the same. We use the Lloyd Davis position here, and we have
Here,
to
Lloyd Davis position is especially helpful because the surgeon may have to sometimes come and stand in between the two legs of the patient and maneuver the instruments and do the stapling, etc. So it is particularly helpful. Next.
So first we have to expose uh, expose the sigmoid colon by moving the transverse colon, the small vowel, the small vowel to the right quadrant, the right upper quadrant, and
That's
also
by
the
positioning of the patient, etc. You will achieve that. Okay.
After that, we have to
In laparoscopy, you can't pack off the small intestine.
Yeah. So we have to first retract by holding the mesentery at the distal sigmoid colon, and then we retract it laterally and laterally and anteriorly. That way, we can enter the retroperitoneal plane by incising.
When you are dissecting medially, when you are pouring the peritoneum medially and going in, you have to be vigilant about the ureter. You identify the ureter at the crossing of the iliac vessels also, and then
we have to like push it posteriorly so that we can prevent it lifting with the mesentery when we move forward.
Then
And
you go
then
on mobilizing.
and till we have to like mobilize till we remove all the colonic and peritoneal attachment in the side walls. And once we
Now,
reach the
once you have done the mobilization, then how will you do the anastomosis or resection? You may either do, you may deliver the specimen out through a small incision and then you cut outside and do extracorporeal anastomosis, or you can do intracorporeal also by EES staplers. Okay. Or even endostaplers you can use, like linear cutters, endolinear cutters you can use. Yes. So what is the literature about oncological safety of laparoscopic technique? Whatever literature was available comparing standard left hemicolectomy by open or laparoscopic technique, it was found that laparoscopic technique is as good for oncological purposes. Oncological safety was as good with laparoscopic as with open. Now with the onset of CME and CVL, literature is, robust literature is yet to be found on the oncological safety of laparoscopic technique, in especially in left-sided tumors. So it is yet to be seen. Now, what other surgical modality is being used nowadays for these kind of surgeries? Sritama?
Yeah, you mean for left hemicolectomy?
You may do robotic also, but since robots are especially useful where in difficult to access areas of the abdomen like pelvic surgery, etc. So the obvious advantage of robotic surgery is not much, not much useful in this case, in these kind of cases. So how can you assess the ends for adequate vascularity before doing the anastomosis?
So we have to see if there's adequate bleeding from the margins.
Bleeding from the margins, but you said you will cut the specimen with staplers. Staplers are already applied. So how can you assess for bleeding?
Any new modality? You can inject and then you have the camera, you can see.
Indocyanine green can be used and infrared, infrared camera can be used to pick up the fluorescence to see what is the vascularity of the ends. So this is one new modality that is there. And how will you prepare one end for anastomosis? The line of anastomosis should be made free of all fat, mesocholic fat, etc. That should not interfere with the line of anastomosis. And when you are doing anastomosis, you should be very careful to align the proximal and the distal. You should not start with the anti-mesenteric border of proximal and mesenteric border of the distal end. Okay. Sir, আপনি আর কিছু question করবেন?
Post-op.
Okay.
Post-op care.
So post-op care, what will you do as per conventional?
You have not done a diversion. You have not done a diversion. Primary anastomosis. What is the post-op management for such patient? How far? How long IV fluid? When do you start oral fluid? What is the recommendations?
Sir, at present, if we follow the ERAS protocol, then we can remove the rice tube after operation, and after that we can start oral liquids the next.
Yes, Sitama. For a left hemicolectomy, right tube is not really inserted at all.
Right tube won't be put at all.
You don't.
Urinary catheter.
Only if you have operated in the emergency with a patient with obvious obstruction, vomiting, abdominal distension. In that case, you may have put a Ryle's tube. But if you are doing elective left hemicolectomy, you won't put a Ryle's tube altogether for left hemicolectomy. So Ryle's tube
so the strategy is to start early oral feeding. Early oral feeding, maybe by within 24 hours you can start. Okay, you can start a trial feed. That is called a trial feed. Okay. So if the patient can tolerate, they can find that. He said that if you start oral feed early, it enhances return of peristalsis. Okay. What is the antibiotic strategy? Antibiotic?
The antibiotic strategy, we start at the induction of anesthesia, and we can continue for one more dose post-operatively, or if the surgery extends for more than 4 hours. And if there is any contamination during handling, then we can continue antibiotics for the next 3 to 5 days.
Okay.
How do you suspect patient has a leak? In the post-op period, how do you suspect that there is an anastomotic leak and something is wrong? What are the pointers to a leak?
Sir, first of all, patient will have vital signs changes like
before vitals. No. Before vitals, patient will have some problem. He will not be same amount of recovery. He will give some signal. He will have pain. Some post-op pain is expected. Some post-op pain. When there is a leak, there will be evidence of local peritonitis. Okay, so patient will have pain, which will be more than the expected post-op pain. And then, because of local sepsis, patient may have fever. Patient may have fever. You have put a drain. If you have put a drain, you can find there is feculent discharge to the drain side. So they are the main pointers. And then go to the vitals. What is the earliest change in vitals? Earliest change in vitals?
Pulse rate.
Yes. That is a very important pointer. Patient may not have hypotension at the beginning. There will be tachycardia. Okay, that is an important marker that something is wrong.
And so how will you confirm? How will you confirm if there is a leak or not?
So you have to do a ultrasound and see if there is presence of any like.
It may give idea about collections, but the investigation of choice would be a CECT. CECT will give an idea as to how much the leak is. If it is a content leak, apart from what is draining out, or if it is a leak after you have removed the drain, then you can again put in a CT guided pigtail or something. If it is draining out adequately, patients' vitals are improving, counts are coming down, the inflammatory markers like CRP procal are coming down, and patient is symptomatically better, pain has subsided, then it is fine. Otherwise, you have to do again a reapparotomy and fix the problem. Okay.
Yeah.
So
Yes.
How will you
Thank you.
suspect burst abdomen? Burst abdomen to discuss for sir. How will you suspect burst abdomen?
Yeah. Yeah. Yeah.
Burst abdomen, if there is discharge from the wound site, we can see salmon colored discharge from the wound site
License.
and wound essence, yes.
When?
So
When?
early,
Which
And
day? Which day? Which day?
which day?
sir, for post of day 5. For
5 na, ideally 7 to 10 call, and there is an antecedent serous
Yeah.
kind of discharge which gradually becomes like dirty dishwater kind of dishwashing fluid kind of discharge, and if there is associated leak, then later on there may be fecal discharge also. Not necessary always there will be fecal discharge or anything. There may be just serous discharge also, which may be a pointer towards, and then gradually it may become pinkish in color and then dirty, which may be a pointer towards impending pudescence and burst abdomen. Okay, and the chances increase if you have done if there is contamination during surgery, and if you have done a diverting stoma, that these increase the chances of postoperative burst abdomen. Okay, I think we have covered the topic more or less. And if you
Yeah.
have applied ERAS protocol, how do you know that the patient is fit for discharge?
What are the criteria for discharge?
no, if
There
the
are
patient,
three
if
criteria
the
for.
patient is
Patient?
so if the patient is feeding orally properly, if there is
First is
adequate
pain free.
feed,
Patient should be pain free. Patient should be pain free. Patient should be ambulant,
and
and
discharge,
patient should be taking
yes,
oral diet. There
yes,
are three
oral diet
criteria
and the
for
patient,
discharge.
yes. And if there is no
Okay.
other evidence of paralytic IBS and bowel movements are fine.
It need not lengthen this. This three statement is
Okay.
covering all.
Okay.
Thank you, sir.
Thank you.
I
Thank
think we
you.
have covered the topic.
Uh,
Thank you.
yeah,
Sir.
yeah. Abraham sir, any comment?
Abraham sir is there.
Yeah. Okay, then. Milind,
Yeah, thank
we'll
you,
conclude.
Doctor.
Oh,
I was
yes,
just
sir.
coming on.
Sir.
I enjoyed
Yeah,
the
yeah.
talk, description, everything. The indications for left hemicolectomy, you may add on diverticular perforation.
Yes.
Yeah.
As after there are criteria for opening the patient, both as an emergency as well as electively. Diverticular disease as such, either perforation or extreme bleeding when you have exhausted on radiological methods, that would be another indication. Strictures, again, limited resection, that kind of thing. I think you have covered most of it. One more newer thing which has come in the post-op leak would be a endoluminal VAC application,
Yeah.
especially in lower rectal dehiscence. You have now endoluminal VAC application. So this is something which has come in the news. So my contribution is only that. Rest of it is
Thank you.
covered well. Thank you.
Thank you, sir. Thank you. Thank you, Sitama. You answered well. Thank you.
Thank you.
Okay. Okay, Milind. Thank you.
Thank you, sir.
Thank you. Thank you.